Hello everyone. In this video we will talk about the complete heart block or the third degree AV block or third degree heart block. And if at the end of the video you think the video is good, then please like the video, subscribe to the channel and also share the video. And you also need to press the bell icon so that every next video will be available to you automatically the moment it is uploaded. Thanks for watching the video. So before we talk about the complete heart block, which is also known as the third degree heart block or third degree AV block, we need to talk a little bit about the pacemaker of the heart. We used to call it the pacemaker of the heart, but here we see it's written the pacemakers of the heart. The reason is we used to think that if this is the conduction system of the heart, we have got only one pacemaker, which is the sinoatrial node or SA node, which is calling the shots or which is running the rhythm of the heart. But this is far from the truth. Why? Let's talk about it. Here we see that SA node, which is normally is pacing the heart and is known as the normal pacemaker. It transmits or generates impulses at a rate of 60 to 90 times per minute, and those impulses which pass from here to the atria, and the atrial depolarization causes the P wave on the ECG. Then it comes to the AV node and goes all the way down through the Purkinje system inside the ventricular muscles and causes the ventricle to depolarize, and that generates a narrow QRS complex. Those QRS complexes which are generated as a result of the impulse coming from the SA node will generate narrow QRS complexes. What we mean by the narrow QRS complexes, those QRS complexes which are shorter than 3 small boxes or shorter than 0.12 seconds are known as the narrow QRS complexes. So it was a nice simple story which we always hear. But there are two other potential or hidden pacemakers inside the conduction system of the heart. And what are those? One is located at the level of the AV node and bundle of His. This is known as the junctional pacemaker. Why? Because it's located at a position which is at the junction of the atria and the ventricle. So the junctional pacemaker, it will potentially generate impulses at a rate of 40 to 60 times per minute, and in majority of the cases these will be the narrow QRS complexes. From where will come the narrow QRS complexes? From the ventricular depolarization. Why we call it in majority of the cases? Because when the block is at the level of the AV node and its upper portion. But in those cases where the block is even involving the bundle of the His, the QRS complexes will be broader. So broader QRS complexes are the one which are longer than 3 small boxes in duration or longer than 0.12 second. This is an important concept. So junctional pacemaker is located here and it's dormant normally, and we will talk about its dormancy in a minute. Now the third pacemaker, which is a potential or the dormant pacemaker, is at the level of the Purkinje fiber and the ventricular muscle, and this is known as the ventricular pacemaker. It will potentially generate impulses at a rate of 20 to 40 times per minute, and it will be surely the broad QRS complexes. And what we mean by the broad QRS complexes, if you look at here, the broad QRS complexes are the one which are broader than the 3 small boxes or broader than 0.12 seconds. So normally when the heart is being run by the SA node, sinoatrial node, and it is throwing impulses at a rate of 60 to 90 times per minute, everyone in the family of the conduction system and the ventricular muscles of the heart, they are happy obeying the commands of the pacemaker which is generating the most number of the impulses. So this is what happens, that where the number of the impulses are more, heart is happy to obey these commands, and these two pacemakers, junctional pacemaker and the ventricular pacemaker, they remain dormant. So we see 60 to 90 times per minute P wave, we see 60 to 90 times per minute QRS complexes, and these are narrow. So there are 3 pacemakers in the heart and they remain dormant. Rest of the two of the 3 remain dormant as long as there is no blockage over here. When there is a complete blockage at the level of the AV node, then these dormant pacemaker will rise up to save the life of the person and to save the myocardium. Because if they do not wake up, then because of this complete blockage, which we call the complete heart block or the third degree of heart block, there will be P wave, because atria will depolarize even before the AV node entry of the impulse. But there will be no QRS complexes, because no impulse will be transmitted downwards, because there is a complete blockage of the AV node. So these two pacemaker will wake up and try to run the ventricular systole, so that blood pressure can be saved and the person's life can be saved. Now we should not forget 2 or 3 important facts, that normally when we see a PQRS complex and the T waves, then what it denotes, P is the atrial depolarization which is happening here, and QRS complex is the ventricular depolarization which is happening here. So in between is the AV node. When the impulse is passing through the AV node, it generates this PR segment, which is from the end of the P wave to the start of QRS complex. So a very important message here, P wave is generated on the ECG paper well before the AV node, and QRS complexes is generated once the impulse has passed through the AV node. So whenever there is a complete heart block or third degree AV block, where there is a complete blockage of the AV node and no impulse from the atria, from the SA node is allowed to pass through it, then P will not be affected. Why? Because atrial depolarization is an event which is happening well before this event. So it will not be affected. It will be the 60 to 90 times per minute P wave on the ECG paper, if the patient has got no sympathetic activation or parasympathetic inhibition of the SA node. But if there is a complete blockage, then only the QRS complexes will be affected. Only the ventricular depolarization will be affected, depending upon of the two dormant pacemaker, junctional and ventricular, which one is awakened. If the response is coming from the junctional pacemaker, the ventricular systole, ventricular depolarization or the QRS complexes will be 40 to 60 times per minute, and chances are that there will be narrow QRS complexes. But in case when even the blockage has involved that part of the junctional area where this pacemaker is located, if there is a complete above and lower part blockage or of the AV node, then only the ventricular pacemaker will wake up and try to run the myocardium or the ventricle, and it will generate QRS complexes at a rate of 20 to 40 times per minute, and these will be broad QRS complexes. So the most important message is to remember that in complete AV disassociation, in complete heart block, in third degree heart block, P wave will not be affected. Only the morphology and the rate of the QRS complexes will be affected, and that way P will lose its association with the QRS complexes. For example, if P is being generated at a rate of 60 to 90 times per minute from the SA node, and QRS complexes are generated either by the junctional pacemaker at a rate of 40 to 60 times per minute, or by the ventricular pacemaker at a rate of 20 to 40 times per minute, there will be no association. Because normally what happened when the SA node was the normal sinus pacemaker and it was generated the normal sinus rhythm, remember from our previous video that we have discussed that a normal sinus rhythm is when the P is always followed by the QRS complexes, because this is the same impulse which is being generated by the SA node, goes all the way down to the conduction system and activates or depolarizes the ventricle muscles which generate the QRS complex. So in normal sinus rhythm, P is followed by QRS complexes, but in case of the complete heart block, there will be a complete disassociation between the P and the QRS complexes. So atria and the ventricle will be divorced. So the P will no longer be married with the QRS complexes. This is an important message. Now if you try to focus on these ECG tracings, then here you see this is a normal ECG tracing where you see a very fine P wave before each QRS complexes. So the P is married to the QRS complexes. Our atrial depolarization is followed by the ventricular depolarization, because there is no problem at the level of the AV node or anywhere in the conduction system. So the rate is around like 60 to 90 times per minute for both for the P and the QRS complexes. But take this example here, the blockage is at the upper part of the AV node. It's not involving the even lower part of it. So a bundle of hairs is spared. When blockage is at the level, the blockage is complete and it's at the level of the upper part of the AV node, then the chances are that the lower part of the AV node or bundle of hairs where the junctional pacemaker is located, it will be activated. Now it will generate its very own QRS complexes which will be narrow and which will be 40 to 60 times per minute. So here you see the rate has fallen from here. The QRS complexes, they are still narrow, they are still less than 3 small boxes, they are still less than 0.12 second, but their number is less as compared to this above tracing, but the number of the P wave is staying the same. It's the still 60 to 90 times per minute. Why? Because P wave is being generated by the atrial depolarization, which has got nothing to do with the blockage of the AV node. The generation of the P wave as a result of atrial depolarization is an event which is happening before the impulse even tries to enter the AV node. So P wave remains 60 to 90 times per minute, but its association with the QRS complexes is lost. Why? Because the frequency or the rate of the QRS complexes or the ventricular depolarization has changed now. It has dropped from the 60 to 90 times per minute. It has come to the 40 to 60 times per minute. But always remember one thing, ECG paper is an innocent paper. It is only an event recorder. When the atria depolarizes, it records the P wave. When the ventricular depolarizes, it records the QRS complexes. When all this was happening in a synchrony, in a harmony, it was recording P before each QRS complexes. But here the ECG machine and the paper has to record both these events, but here they are not in harmony. They are desynchronized. This happening at another time, this happening at another time. So here you will have to look for the P waves which may be anywhere in the ECG tracing. They may be embedded right into the QRS complexes like here. They may be right on top of the T wave like here. They may be before the T wave. They may be after the T wave. So P will maintain its frequency or rate as normal, but it may be located at anywhere. So the first thing which will point towards the complete heart block will be that there will be loss of the association between the P and the QRS complexes. Now these both are divorced. They are living their independent life. They do not have harmony with each other. So the first indication whenever you look at an ECG, if you do not find an association between the P and the QRS complexes, always suspect that there can be a complete heart block. Try to look for the rate of the QRS complexes and also the breadth or duration of the QRS complexes. That will hint towards which pacemaker is activated as a result of complete blockage at the level of the AV node. Now this second example against the normal tracing of the ECG is that of the complete heart block when there is activation of the ventricular pacemaker. Now look at here, try to focus here. The AV node is completely blocked. Both the upper and the lower portion of the AV node, including the bundle of his, they are blocked. So there is a complete blockage of the AV node. Now only pacemaker which can save the life of the patient for the time being, or which can try to run the heart or pace the heart or pace the ventricular muscle, is the ventricular pacemaker, which will be generating QRS complexes at a rate of 20 to 40 times per minute, and these will be the broad QRS complexes. These will be more than 0.12 second or more than 3 small boxes in duration. So the first thing you will try to notice in these patients, you will not find an association of the P with the QRS complexes, but you will have to then look for the P wave, because the P will be coming at a normal rate of 60 to 90 times per minute, but it may land anywhere on the ECG tracing. So you will have to look for it. May be embedded or it may be buried somewhere in the QRS complex. It may be on the isoelectric line. It may be on the top of the T wave. It may be before the T wave or after the T wave. So P will remain at a rate of, or will be coming at a rate of 60 to 90 times minute. QRS complexes will be broad and the rate will be 20 to 40 times per minute, and that will show us that this is the junctional pacemaker which is now trying to pace the ventricular part of the heart. So this is a complete heart block with the ventricular pacemaker. And why it happens in these patients? Because of the cardiac ischemia. Major cardiac ischemia is one of the major reason. Then there can be electrolyte abnormalities, like if there is a patient of the chronic kidney disease or end stage kidney disease and patient has developed hyperkalemia, then majority of these patients, when the potassium goes above like 7 or 7.5 millimole per liter, they present as a case of the complete heart block. It may be ischemia, it may be hyperkalemia, it may be any cause like this. But if the cause is not immediately correctable, you are to pass the temporary pacemaker. And if the cause is not the ischemia, or ischemia is resolving after a week, then patient may not need the permanent pacemaker. And same is the case in case of the hyperkalemia is managed properly. But if it is there for another week, then you will have to pass the patient with the permanent pacemaker. So the treatment of the complete heart block will be pacemaker, but before that we can attempt atropine, we can attempt dopamine, we can attempt isoproterenol. So these are the temporary measures to increase the heart rate so that patient does not become the hemodynamically unstable.